Pathology of invasive breast cancer. The classification of invasive breast cancer begins with the morphological appearance of the cancer by light microscopy, and the widely used WHO classification based on the growth pattern and cytological appearance of invasive tumors. Although the classification system recognizes invasive ductal lobular carcinoma, and these terms do not imply that the former originate in the ducts and the later originate in the lobules. Most invasive breast cancer, they arise in the terminal duct lobular unit regardless of the type, and most common histological type of the breast cancer is the invasive infiltrating ductal carcinoma, accounting for 70 to 80% cases. Diagnosis of invasive ductal carcinoma is diagnosis by exclusion. This type of is defined as the type of cancer not classified into any other specific categories of invasive mammary carcinoma, such as invasive lobular, tubular, mucinous, medullary, and other special types. Emphasis of this point: most classification system use the term infiltrative ductal carcinoma, not otherwise specified, infiltrative carcinoma, not otherwise specified, and not otherwise no specific type is the preferred nomenclature at present. And in practice, the terms invasive ductal carcinoma, infiltrating ductal carcinoma, infiltrating or invasive carcinoma of no specific type are used interchangeably. And special type of cancers comprise of 10 to 20 to 30% of the invasive breast cancer. And classic tubular carcinoma or classic mucinous carcinoma, if less than 1 centimeter size, have a very low incidence of axillary nodal mets, and which may affect the management decision. Special types have a classical histological feature like lymphoplasmacytic infiltrate that characterizes medullary carcinoma, or the single file appearance of lobular carcinoma. Lymphoplasmacytic infiltrate in medullary carcinoma. Breast cancer with pure tubular, mucinous, papillary, or cribriform feature have favorable outcome. Tubular, mucinous, papillary, cribriform, they have a favorable outcome than those with more common types of breast. And micropapillary tumors carry a higher incidence of lymphatic or vascular invasion and systemic recurrence. Although seen more frequently in other locations, squamous cell adenoid cystic secretory carcinoma can also develop in breast cancer. Over 90% of the tumor should be demonstrated the defining histological characteristic of a special type of cancer to be designated as that histology type. Tumor subtypes that occurs in the breast but that are not considered to be typical breast cancer include cystosarcoma phylloides, angiosarcoma, primary lymphoma. Invasive breast cancer are subclassified by grade, either solely on the nuclear features like nuclear grading, or combination of the architecture and nuclear characteristic histological grading. In nuclear grading, the appearance of the tumor cell nuclei is compared with that of the normal breast epithelial cells, and the tumor nuclei are classified as well differentiated, intermediately differentiated, poorly differentiated. More common current practice is the histological grading based on the evaluation of tubule formation, nuclear pleomorphism, and mitotic activity. The Nottingham grading system by Alston and Ellis, modification of the grading system proposed by Bloom and Richardson in 1957, recommended part of the AJCC staging, and tubule formation 75%, 10 to 75%, less than 10%. Nuclear pleomorphism small to uniform, moderate variation in size and shape, and marked nuclear pleomorphism. Mitotic activity per filled area are each scored on a scale of 1 to 3, and the sum of score of these three parameters are overall histological grade. Like score 3 to 5 is grade 1, 6 and 7 is grade 2, and sum of 8 and 9 they are grade 3, poorly differentiated. And histological grading, particularly the distinction between grade 1 and 3, has prognostic significance. So what is the prognostic and predictive factors in breast cancer? Prognosis and treatment of the breast cancer are governed by stage of the diagnosis. Stage reflecting the anatomical extent of the disease. Stage is the reflection of the anatomical extent of the disease and by the underlying biological subset of the tumors. Clinical subtype of the breast cancer are defined by the expression or lack of expression and key biomarkers include ER/PR, HER2, which correlate with a variety of the pathological varieties such as grade and genomic features of the breast cancer. Based on established clinical, pathological, and now biological prognostic factors, stage, particularly the extent of the axillary lymph node involvement by breast cancer, remains a significant prognostic factor for the development, subsequent metastatic disease, and survival. Tumor size and histological grading also establish prognostic significance. So, axillary lymph node, tumor size, grade, histological grade. Tumor size is typically given as a microscopic size of an invasive cancer. The utility of histological grade is guarded either under the microscope or genomic assay, especially intermediate grade may be diminished because of the persistent challenges in the interpretation. ER and PR expressions, they are determined by IHC technique and are important prognostic and predictive factors. Patients with invasive breast cancer whose tumors are totally lacking this ER and PR do not derive benefit from hormonal treatment. Tumors that strongly express ER and PR have a better prognosis. Tumors that express ER/PR have better prognosis than treated with the endocrine therapy. Patient's age is another prognostic factor, and very young age, less than 35 years or younger, have histologically poorer prognosis than older patient, and largely due to greater prevalence of high-risk pathological tumor features in this group, including greater likelihood of higher grade tumors with the lower levels of ER expression and greater frequency of high HER2 amplification. Molecular subtype is probably a more important factor than patient's age. So, as adjusting for molecular subtypes resolves much of the adverse effect of younger patients. In a retrospective analysis of patients treated with in the NSAPP B14 trial validating 21 gene SF or prediction of the chemotherapy benefit in women with node-negative ER-positive breast cancer treated with tamoxifen, age was no longer significant predictor of distant recurrence after recurrence score was included in a Cox model. Age younger than 40 years remains the adverse prognostic factor in ER-positive luminal cancer. However, no impact of age on breast cancer specific survival is seen with triple negative and HER2 positive. So, approximately 20% of these patients with breast cancer have HER2 new amplification, which is highly correlated with the glycoprotein overexpression. HER2 amplification or overexpression is associated with a high tumor grade and lower expression or low hormone receptor, higher levels of tumor proliferation and heavier monodal tumor burden. And HER2 status is major predictive factor for benefit from anti-HER2 therapies, and which I discuss later. HER2 status is predictive of benefit from the anthracycline-based chemotherapy, although the significance finding is unclear in the era of anti-HER2 targeted therapy. Measurement of HER2 can be performed by either IHC or fluorescence in situ hybridization. In practice, tumors that are considered HER2 plus 3 by IHC or that show evidence of the HER2 gene amplification with copy number greater than 6 or ratios more than equal to 2 warranted treatment with anti-HER2 therapy. So, if the HER2 is plus 3 by IHC or show evidence of gene amplification with copy number greater than 6 or ratio more than equal to 2 warrant anti-HER2 therapy, and HER2 status is positive if there is evidence of protein expression IHC or gene amplification not only by in situ hybridization but also by copy number. Tumor with elevated HER2 new gene copy number of more than 6 without amplification relative to the chromosome 17 centromere copy number are also considered HER2 positive. But there are few data on the benefit of trastuzumab in such cases. Tumor involvement of lymphovascular space is associated with a greater likelihood of lymph node mets. Involvement of lymphovascular space and is an independent adverse prognostic factor in node negative patients. Thank you.